If you're a nurse educator, you've probably gone over the nursing process hundreds of times. You've explained clinical judgment, but you can see that for many students, they still aren't connecting the dots to thinking like nurses, especially in clinical. And that's the exact challenge that I kept seeing as an educator. And I'm Keith, and I've spent 25 years as an ER nurse before becoming a nurse educator. And the 6 R's of clinical reasoning is a teaching framework we've developed based on Tanner's model to help make clinical judgment easier to teach for the educator and empowering and easy to remember for the student. The first R is recognize what's relevant. In the clinical setting, students are often overwhelmed by too much information. Vitals, labs, assessments, background diagnoses, and physician notes. Without a clear filter, they either latch onto irrelevant data. Oh, her potassium is a little low at 3.4. Maybe that's it. Or they miss the urgent red flag entirely, like a rising respiratory rate or new onset of confusion. This step teaches them to ask, of all the data in front of me, what actually matters right now. The second R is relationships recognized. After identifying key clinical data, students must interpret what those cues mean in relationship to each other and what they point to as a whole. The issue is students often see each piece of data in isolation. They recognize a low blood pressure or increased drainage or an elevated temperature, but they don't interpret how those signs relate to the bigger clinical picture. Take this example. A confused elderly patient has a low-grade fever, tachypnea, and a new episode of incontinence. The goal is for students to recognize that this cluster of findings could point to an early sepsis from a UTI. This is what the second R, relationships recognized, teaches. What do these findings mean when you put them all together? And what's the underlying cause? And by the way, if you want a hard copy of the full 6Rs framework to use in your classroom, you can download it for free. Link is in the description. The third R is respond to the current priority. Once students recognize key data and interpret its meaning, they must decide what action takes priority right now. It's great to be able to recognize what's relevant and recognize the relationships, but if the wrong prioritization takes place, this can be fatal to the patient. When a patient is short of breath, has declining oxygen saturation, and looks pale, students need to know that applying oxygen and calling for help comes before checking labs or documenting in a chart. This R takes students from thinking to prioritization and doing. The fourth R is risks and red flags recognized. This critical step is not made visible in Tanner's or the NCSBN clinical judgment measurement model. Yet as an ER, ICU, and rapid response nurse, I ask myself this critical question every shift. Students too must learn to anticipate potential complications or deterioration based on the current clinical picture and recognize early warning signs before they escalate. This step of recognizing risks made visible can be the difference between patient life or death. Because new nurses often respond reactively, waiting until something goes wrong. But safe practice requires proactive awareness and vigilance. What might happen next? What's the worst case scenario and how can I prevent it? Imagine a post-op patient with a rising heart rate and slightly dropping blood pressure. Those might not trigger an automatic alert, but they're red flags. A thinking nurse will recognize that and start thinking, could this be bleeding or sepsis? Do I need to intervene now or closely monitor? Risk recognition is crucial and must be made visible for safe patient care. The fifth R is re-evaluate the patient's response. After an intervention, students must assess the outcome. Did it work? Is the patient improving, deteriorating, or unchanged? This closes the clinical reasoning loop and keeps care dynamic and responsive. Too often, students treat care like a checklist. Give the med, do the intervention, document. But thinking nurses are always evaluating what changed, what didn't, What's the next best step? If you administer oxygen and recheck the vitals, is the respiratory rate slowing? Is the O2 sat rising? Is the patient more alert? If not, there's more to be done. The sixth R is reflect and refine thinking. The nurse must evaluate and reflect on decisions made each time patient care is provided to strengthen and develop clinical judgment. Yet it's not made visible in the nursing process or the NCSBN clinical judgment measurement model that ends in evaluation of the patient. After care is delivered, students must reflect on their thought processes, decisions, and outcomes of the patient. Questions like, what did I learn? What could I do the same or differently next time? If a student handled the situation well, wonderful. Ask them what helped you recognize that early. Or if they missed something, even better, ask what do you think would have happened? What could have been done differently to prevent that in the future and to improve patient outcomes? This is where significant strides in learning can occur for our nursing students. And again, to use the 6 R's in this teaching framework, the link to download is in the description.